Good afternoon, ladies and gentlemen, and I would like to give a special thanks for the organization coming to have me here, and also it's my honor to present today on behalf of the scholars for the first time. We will go in a short debate between me and my friend Dr. Mustapha, which we will discuss PRK versus LASIK, back to surface or go in deep. My disclosure, this is 5-minute talk, so I will not go in very literature review for LASIK versus PRK. Instead, much of this talk will go in my personal preferences, opinion, experience. In general, actually, I embrace a new technology. Always I follow, I like new technology. I do LASIK, femto LASIK, smile, but now exclusively perform PRK. Let's go on and see why I'm now only perform PRK. After a long day in my clinic, do so much PRP for patient, putting a plan for the VR list and do a lot of things. I remember today is my LASIK list. And LASIK list for my family stress. For most of the ophthalmologists is easy money. And also for VR surgeons is like a corneal foreign body removal. So I start my list, I do the first 2 cases, everything was done very smoothly till I reach to the left eye of the 3rd patient. Let's see what happened there. I start putting the keratome, finish the keratome, now we have a free flap identified. So this is my appearance during the procedure. I will tell you now why. But I was lucky in that day because I can identify the flap. I take the flap out. Now slide it. Take the flap to the side. Then removing the blood. And starting laser. And put the flap back to its place. PSS, and this time, actually, we will wait more than the usual time for the flap. Here I use the double sponge technique, in which one sponge I will fix the flap, the other one is to make the milking now, and everything is gone well. Putting the contact lens. After the procedure, I ask myself, we are operating on six patients. So like we are doing cosmetic surgery for the patient when it comes. So why we want to enter ourselves in so much trouble? Why we don't go back to the surface? I ask myself. So we know, ladies and gentlemen, excimer laser and corneal refractive surgery started by a PRK since 1960. So it's 30 years old, this procedure are done, and we still do these procedures. And after that, we do so many LASIK, epi-LASIK, smile, but till now, we are do PRK. So regarding the stability, actually 100% of patients, about 3 months, they reach the stability, about 0 diopter. Regarding the uncorrected visual acuity, also about 100%, they reach about 3 months. Efficacy, if we see here, that about 100% of patients are within plus minus 1 diopter. So, if we go for advantage of PRK, I don't have flap, so I don't have any intraoperative complication, plus fewer incidents of high-order operation, plus it's a cheaper, easy, and I don't have the risk of ectasia. This is number 1. Plus that, I have now a complete surface of my of the cornea, so it's the iris will be easily registered. If I want to planning for customized ablation, I don't have making a flap, so it will not interfere with the biomechanical of the cornea. On the other side, disadvantage of LASIK, we have a flap complication. We have a high risk of ectasia, high cost, dry eye, glare and halo. What are the complications of PRK, ladies and gentlemen? It's the same complication for all of the refractive procedures, like halos, decentration. I know now they will ask me, what about the corneal haze? Corneal haze, it's actually when this paper was published on 2017, they discuss and compare the effect of mitomycin C. Actually, the result of the study, they say that the haze incidence is about 2.1, double the incidence in cases of high myopia. So only in high myopia we have 2.1% incidence of haze. Of course, for me, no stress. You are doing a procedure without stress. Let's go little in literature. I have so many studies to compare between myopic and hyperopic. The two, in case of myopic, the two techniques appear to give similar outcome after 1 year. And also, in cases of hyperopic, there is no any statistical difference between on the long term. So this is the easy PRK technique that we use. I started with putting tetrakinase sponge on the surface of the cornea, and also put it slightly on the conjunctival surface, touching the lid surface, which I believe it's reduce the pain. Putting alcohol for 20 seconds, and after that removing. We have to be more serious, and we not making. Now I starting do what is called epithelial rexes, which is the same that we do in cataract surgery. It's like we are doing capsular rexes, but now it's called epithelial rexes. Some say we can use this epithelium to cover the cornea back, but actually I don't. I disregard the epithelium here, and putting the laser. This is mitomycin C. Irrigation with a cold BSS, steroid drops, and the contact lens finally. Very easy procedures. Other things about the post-operative regime. What I use, actually, if less than 5 diopter, I use mitomycin. I use steroid for 4 to 6 weeks. Maybe I extend the period of steroid if I have a long duration or more diopters. Antibiotic for 1 week, vitamin C, omega-3. What's regarding the pain control? Ladies and gentlemen, I do so much procedure for PRK, so many patients. I give them as a questionnaire. Mostly they complain from pain for the first 24 hours. Rarely they extend more than 48 hours. So I just give them non-steroidal, topical non-steroidal, and systemic olefin, one cold compress. What I don't use oral steroid, I don't use oral narcotic, and I don't use tetrakinase. Regarding the visual result, for this is my patients, I do for them follow-up for 6 months, and immediately after procedure we have about most of patients exhibit the wow moments, and in post-operative day approximately 90% have 6-6, post-operative day 4, majority also go back to the work, post-operative 1 month 6-6, post-operative 6 month 100% are 6-6. So in conclusion, it's a safe procedures. There's no flap complication. I don't have a risk of ectasia. It can be customized. It's a comparable regarding short and long term, and easy to use. Ladies and gentlemen, in refractive surgery, we are started by BRK, then we do LASIK, and EpiLASIK, and we go back to BRK. And now we are using SMILE. But maybe after 10 years or 15 years, we also go back to BRK. We don't know till now. So this picture, I know this is SMILE, is very nice SMILE, and I hope that we have like this SMILE in practice. But for me and my patient, having SMILE is much more better than this SMILE. Thank you very much.
Not على الستيج. Not على الستيج. Okay.
ما يتحرك من وصل الدقيقة هذه. يلا.
Okay, thank you, Dr. Muhammad, for your nice presentation. As we see, you shift from the LASIK and go back to the BRK because you have the intraoperative complication, you have a free cup. I just want to remember you that BRK is not free of problems. You may have corneal haze, epithelial healing problem, and slow rehabilitation and regression in refraction. Corneal haze is common in the BRK. It may be occur early and late. And after surgery, the patient may have a risk to develop corneal haze even 4 or 6 months after the operation due to the UV light exposure. Also, you said my use of mitomycin C decrease the risk of corneal haze. This study by Kaiserman published in the PubMed in the 2017 show the use of the mitomycin decreased the risk of corneal haze, but still 2.1% in the patient with high myopia and 10.8% in the patient of the hypermetropia. And I think this is still a high incidence due to the large number of refractive surgery you do. Also, the problem of the epithelial healing. You may have persistent epithelial defect, you may have epithelial scarring, infective keratitis. This is a serious complication and maybe affect the visual outcome of the patient. Many studies about the infectious keratitis is higher with BRK than LASIK. Also, the regression and refraction is more in BRK than LASIK because of the more epithelial hyperplasia in the BRK. As you know, rehabilitation and recovery after BRK may take 4 to 6 weeks to full visual recovery, and this is more faster with LASIK. I think if you want to save option, you can shift to the more safe procedure like femto LASIK, less flab related complication, thin flab, less reliability of ectasia, precise depth, and less IOP elevation. Also, you can go to SMILE. As you know, SMILE, there is no flab. So this is a better option involved in the eye for the patient with the contact sport or jobs with the chance of injuries. Many studies about the biochemical changes after the SMILE is less than other refractive surgery. Also, less incision cut, so the less dry eye and less corneal sensitivity, less effect to the corneal sensitivity. 80% less cut, that means that the chance of complication like infection and epithelial ingrowth is reduced. So the summary, BRK have advantage of stability and no pain and ectasia, but disadvantage of pain and haze. And LASIK have advantage of fast recovery and pain and no pain and no haze. But disadvantage of LASIK is ectasia and the flab related complication. So if we want to take the advantage of BRK and advantage of LASIK and cancel the disadvantage of this procedure, you can go to the SMILE. So go to SMILE surgery and let your patient smile. I think as we shift from the BRK to the LASIK, you must think to shift to the SMILE, and this is one-way direction, and we will not go back to the BRK. Thank you.
Just one question, Mustapha. You do refractive surgery, right?
Yeah.
What now you prefer doing if you want to go to your home safely, don't thinking about the flab and
okay, I'm with you.
You just you want to go without complication and you don't pay anything. We will go for PRK or LASIK.
Okay, I go for BRK.
Yeah,
that's right. But if we want for more safer procedure than LASIK, you can think with the SMILE. We can think with femto LASIK. It is better and easy.
Believe me, sleeping without flap complication is much better than SMILE and everything. Thank you very much.
Okay, thank you.
Thank you very much for our presenters. And now we conclude our session, and the next session will be panel discussion by attending Dr. Faris Al-Bakri, Dr. Osama Ibrahim, Dr. Osama Al-Hassani, Dr. Adil Al-Gar'awi, Dr. Muhammad Shafiq, and Dr. Yahya Salah. Thank you very much.